The second Drugs of the Cardiovascular System lecture. So what we're going to talk about now is we're going to talk about the basis behind heart failure. And in order to understand that, there are two concepts that I wanted to introduce to you or remind you about today. So the first one is preload. So preload is the degree of stretch of ventricles before contracting. So it's proportional to what's called the end diastolic volume. So the end diastolic volume is the amount of blood in the ventricles right before contraction starts. Right? So it's the end of the diastole of the relaxation part, and so it's right before contraction or systole happens. And so basically it's the amount of blood that enters into the ventricles. All right. In heart failure, what happens is the preload is increased because the ventricles are overstretched and they can't actually contract that much. Afterload is the pressure that must be exceeded before ventricular ejection begins. So afterload is directly related to aortic pressure, right? So afterload is proportional to aortic pressure. Because what happens is that there's a valve here, right? The semilunar valve that needs to be open before blood can actually be ejected out of the ventricles, okay? And this valve is open only when the pressure inside of the ventricles is greater than the pressure in the aorta, right? It's like you pushing a door. The door, when you push against the door only opens when you exert more force than the weight of the door. And in this case, the weight of the valve of the door in this case is basically the pressure in the aorta. So if for people with high blood pressure, the pressure in the aorta is much higher, right? And so it means that the ventricular pressure needs to be increased before the valve opens. And basically what happens in that case is the ventricles need to contract more and therefore work harder before the valve opens. All right, so those are the concepts, just in a nutshell, of preload and afterload. With heart failure, what happens here, just by the virtue of the name, heart failure means the heart doesn't work, fails to work efficiently. Most of the time, heart failure has to do with dysfunction of the left ventricle when it contracts, right? Or left ventricular systolic dysfunction. And in order to manage or treat heart failure, what we need to do is we need to decrease the preload, the degree of stretch, and we need to decrease the afterload, the pressure against which the ventricles must work in order to open the valve. All right. So the diagram on the right is a diagram of the relationship called the Frank-Starling relationship between the fiber length and the amount of contractile force. And the fiber length in most cases is related to the amount of volume of blood in the ventricles, right? So as more blood enters into the ventricles, the myocardial fibers are stretched. All right, and the more blood enters into the ventricles up to a certain point, the greater the contractile force and the higher the stroke volume. And remember, stroke volume is the amount of blood that leaves the ventricles when it contracts. Okay, so Frank-Starling relationship goes like this. Ventricles fill with blood, muscles are stretched, increase in fiber length, which is the preload, and as you increase the fiber length, you increase the contractile force, the degree of contraction, the intensity of contraction, and therefore you increase stroke volume. In heart failure, though, this is what happens. So you see, this is the normal relationship between fiber length and contractile strength. This is what happens in heart failure. So in heart failure, what happens is as the fiber length increases, the amount of work that the ventricles are able to do don't increase anywhere as much, right? So there's a distinct failure of the heart to do its job with the similar volume of blood in the heart. And what happens is, with the help of the drug digoxin, it actually moves the curve, the Frank-Starling curve, closer towards what's normal. All right. Underlying cause of heart failure, the main two are listed over here. So myocardial infarction. So if you have death of some of the cells in the heart, especially in the left ventricle, it means that those dead cells can't contract, right? And so that causes the heart to fail. Chronic hypertension is what happens when you have the ventricles over here, right? You have the valve, and then you have the aorta, right? So we're talking about the left ventricles. And with high blood pressure, what happens is you've got pressure of the blood on the aortic walls and the valve being exerted to a greater degree, and so the ventricles need to work harder in order to push blood out. And so this is like someone who's been lifting weights. After a while, your muscles just get tired and can't lift any more weight, right? So 5 pounds may seem like not very much weight, but again, if you keep on doing flexing your muscles to lift the 5 pound weight, after a while it just seems tired, right? And won't do it anymore. And so what happens is, with myocardial infarction and chronic hypertension, is that afterload and preload are increased. And so what happens is cardiac output is decreased. And remember, cardiac output is the product of stroke volume and heart rate, right? And so what happens initially, what the effect of heart failure on the heart and other systems is that initially there's no symptoms, and then the ventricles get bigger because basically they can't actually push enough blood out, and so it gets filled with blood that won't move. The muscles get stronger, just like if you were lifting weights regularly, your muscles get bigger. So in the same way, the cardiac muscles get bigger. But there is a point at which the ventricles stop working properly, right? And once the ventricles stop working properly, what happens is the tissues don't get the perfusion, the blood that they need, and so you end up with fatigue, shortness of breath, and exercise intolerance. And because the ventricles aren't pumping blood out to the systemic circulation, you've got fluid overload in the venous system, in the periphery, as well as in the lungs. All right, so the diagram on the right is something that you'll see later on in patho. And so what you have over here is you have the effect, right, of high blood pressure or myocardial infarction. And what happens is, with both of these, you don't have enough blood or enough perfusion, right? And so it triggers a variety of compensatory responses. First of all, the heart will get bigger because the blood isn't leaving it. Secondly, because there's not enough blood perfusing the systemic circulation, it activates two systems, the sympathetic nervous system, to try to increase heart rate, right? And to try to increase contractile force, right? Because of the effect of of heart failure on the cardiovascular system. And also the renin-angiotensin-aldosterone system is activated, and that then leads to an increase in blood pressure to try to pump blood more, and it also leads to an increase in blood volume through the retention of sodium and water, right? And then you've got, this is an effect of the renin-angiotensin-aldosterone system being activated. And through these compensatory responses, you have an increase in venous pressure, an increase in arterial pressure, and an increase in heart rate to try to increase cardiac output, right? But what happens is one of the underlying problem is either is the heart really doesn't want to work, and so what happens is then you have a reduced cardiac output, and that leads to cardiac remodeling. And the cardiac remodeling is the dilation of the ventricles and the heart muscles becoming stronger and thicker. Over here you've got the stages of heart failure, right? And there are two different classifications here. You've got the American College of Cardiology, and you've got the New York Health Association classification of heart failure. Now, I'm not going to go with either one or the other, but if you note the schematic on the right with management of heart failure, it does more closely follow what happens with the stages delineated by the American College of Cardiology, right? So stage A is sort of pre-heart failure, right? At high risk for heart failure, but there's no structural heart disease and no symptoms of heart failure. So in stage A, what happens is management of heart failure is directed at reducing the risk, right? And the risk is, can you reduce high blood pressure? And can you reduce the risk of myocardial infarction happening, right? Stage B, you've got structural heart disease, but it's asymptomatic for heart failure. So again, you want to actually prevent development of heart failure. You want to again reduce the risk, right? Same as stage B, but perhaps give the patient either an ACE inhibitor or an angiotensin II receptor blocker. Stage C, there is structural changes in the heart, and there are some symptoms. So again, one of the things you want to do is you want to relieve the symptoms, right? You want to improve functional capacity and quality of life, so you want to actually improve perfusion measures, and you want to slow down the structural changes that's going along in the heart, and you want to slow down the progression of the left ventricular dysfunction, right? And overall, you want to prolong life, okay? And then stage D is when you have a lot of structural changes, and you have symptoms of heart failure at rest. So this is the person who really can't quite get out of bed, or can't walk to the end of the driveway, or can't walk up the stairs without actually being out of breath. All right, and at this stage, the option is heart transplant with an assistive device in the left ventricle until a heart transplant can be managed. Perhaps diuretics to actually decrease blood volume and decrease blood pressure and decrease the afterload on the heart, but not beta blockers, because that might worsen the symptoms to do with heart failure. So we're going to talk a little bit about that as we go along. So drugs to treat heart failure. Again, one of the big things to ensure that potassium supplements are there if it's called for, and we're going to look at why potassium levels need to be kept at a fixed level. And then frontline treatment for heart failure is a combination of diuretic, ACE inhibitor, and beta blocker, depending on the needs of the individual patient. Right? So what we want to do is we want the heart to work better, and we want to also decrease blood pressure so that we can actually decrease both preload and afterload, and we can increase the amount of blood that leaves the heart. And so you've got the classes of drugs listed here. So diuretics, RAS inhibitors, so inhibitors of the renin-angiotensin-aldosterone system, vasodilators to try to increase the amount of blood going to the heart, beta blockers to stop the heart from working as hard, and Digoxin, which we're going to look at now. All right, so you've got here how it helps to treat heart failure. So I'm going to take pause for a minute and actually just give you a brief overview of what inotropes or inotropic agents are. And you can see here I've actually just taken it out from the website, the texasheart.org website, and so you can get the same information from the website. right? So you've got inotropes. So inotropes are medications that change the force of your heart contractions, and both positive and negative inotropes are used in the treatment of cardiovascular conditions. So positive inotropes strengthen ventricular contractions. Negative inotropes weaken the ventricular force and slows down heart rate. So again, you can see over here that there are various different drugs that are used to treat or to help to manage cardiovascular conditions. So like beta blockers, calcium channel blockers, antiarrhythmic drugs are considered negative inotropes, whereas digoxin is a positive inotrope, because digoxin helps to actually increase the force of ventricular contraction. So this is how digoxin works, right? So what we have over here is we have, so in the normal course of time, what you have here is you have sodium going in, potassium coming out, right? So what you have here, first of all, let's go from the start. Sodium goes in, you've got over here, right? And then what happens as well is that calcium also enters in, and it's the calcium entering in. I'm just going to number them. It's a calcium entering in that makes this plateau, right? And then at the same time, when the slow calcium channels open, potassium channels also then open, and that allows potassium to exit the cell. And then at some point, what you have over here is you have repolarization, and repolarization is helped with the sodium-potassium pump, which helps to pump sodium back out of the cell and to pump potassium back into the cell, right? And at the same time that the sodium-potassium ATPase pump works, it also causes sodium to go in exchange for calcium exiting the cell, right? So again, this is a whole sequence of events that happens. Now what you can see over here, you can see this big arrow, and you can see that the digoxin blocks here. And so what happens when the digoxin is in the picture is that it binds to the same site as potassium. All right, so let's see what happens when effectively the sodium-potassium pump stops working. So digoxin binds to the same site of potassium, stops this from working. And so when this stops working, what happens is potassium doesn't enter into the cell, sodium doesn't exit out of the cell. And when sodium does not exit out of the cell, you don't have this calcium-sodium channel, ion channel exchange happening. And so if you don't have the sodium-calcium exchange happening, what happens is that calcium stays inside the cell, and then calcium levels increase. And when calcium levels increase, this plateau is prolonged, and when this plateau is prolonged, what happens is ventricular contraction is also prolonged, and so it increases it increases basically the amount of blood that leaves the heart, so it improves perfusion, right? And that alleviates the symptoms to do with heart failure. All right, so again, I've got it over here. So mechanism of action is to inhibit the sodium-potassium ATPase pump. And so what happens when this is inhibited, what happens is the amount of sodium inside the cell increases, and so it inhibits the calcium-sodium exchange, and so the amount of calcium increases, right? So it increases intracellular calcium, and when intracellular calcium is increased, then you increase the force of contraction, you increase stroke volume, right? And with that, you also increase the firing rate of autonomic fibers, and so you basically increase responsiveness of the sinoatrial node to acetylcholine, and that decreases the length of the refractory period in the AV node. And remember, the refractory period is the period in an action potential where it's very hard or it's impossible for another action potential to fire. So if you reduce the period, then it means that there's more action potential that can be fired, and so heart rate is increased, right? And so what you have is you have a drug which increases stroke volume, increases heart rate, right? And if you increase stroke volume and heart rate, you increase cardiac output based on this formula. And so you increase cardiac output, then you increase perfusion, like I said. And so the what happens is that the compensatory responses go down, right? So you decrease activation of the sympathetic nervous system, you decrease cardiac dilation, you decrease activation of the renin-angiotensin and aldosterone system, and you decrease the amount of water and blood volume that's retained, and therefore decreasing blood pressure, right? So basically you kind of stop this process. So it improves symptoms, but the disease itself, the underlying disease, may slow down in terms of its progression, but it won't actually be reversed. All right, so this is the action of digoxin. Now, the importance of maintaining potassium levels with digoxin is as follows. One is that digoxin has a narrow therapeutic index. So remember, therapeutic index is basically the level of safety of the drug, and it's the difference between a therapeutic dose and a toxic dose, right? So as I said before, what happens is digoxin competes with potassium. So it competes with potassium on the sodium-potassium pump, right? And so if you decrease potassium levels, then you increase the number of digoxin that can bind, and it can actually reach toxic levels, right? Hypokalemia is often due to diuretic use, and especially with when it's used in conjunction with loop diuretics and thiazide diuretics. And remember, the third class of diuretics are the potassium-sparing diuretics, and so that would not actually induce hypokalemia, right? You've got the signs of toxicity over here, which include cardiac, GI effects, CNS effects, and muscle weakness. And then with the drug interactions, you can see over here, diuretics for that same reason, with ACE inhibitors and ARBs, with sympathomimetics, quinidine, because quinidine affects the QT interval, and verapamil, because verapamil is a calcium channel blocker, right? So basically it reverses the effect of digoxin. Next thing I'm going to talk about is cholesterol lowering drugs, and over here what you have is you just have a little bit of an overview. So you've got HDLs and LDLs, and basically what you want to do is you want to keep HDLs high and you want to bring LDL levels low, right? And it's very convenient with that. All right, so HDLs basically transport cholesterol back from non-hepatic tissue back to the liver, and the liver can then process them. And so HDLs help to protect against heart disease because it collects cholesterol from the blood and shunts it back to the liver, right? LDLs are largely made in the liver, and it transports cholesterol from the liver to non-hepatic tissue, and so it basically promotes the increase of cholesterol levels within the blood. All right, so LDL levels are related to increased risk of developing heart disease, especially with chronic inflammation, right? Because chronic inflammation then increases the risk of atherosclerosis, and with atherosclerosis you've got all this cardiovascular conditions that are associated with atherosclerosis. And so what happens is if you decrease LDL levels, you can halt or reverse atherosclerosis, and then you decrease the morbidity and mortality from chronic heart diseases. So ways to lower cholesterol levels is by a couple of different steps. So the first one, Step 1 is called TLC, for therapeutic lifestyle changes, and it's very similar to the steps used in treating high blood pressure, right? And so it's managing diet, managing weight control, exercising, and stopping smoking. Right? If therapeutic lifestyle changes are not enough to bring down cholesterol levels, then there are a few different drugs that we'll talk about in the next couple of slides that help to do that. Right? The statins are the most effective drugs for lowering cholesterol because it has few adverse effects, and then there are a few other drug classes that are mentioned that we'll talk about more here. So the first class of drugs are the statins, and statins work by inhibiting an enzyme that is in the pathway to synthesizing LDLs, right? So what happens is that it also increases the number of hepatic LDL receptors, right? So you imagine there's the liver over here, you've got LDL receptors. And so what happens is the LDL binds to these LDL receptors, and then the LDL enters into the cell, and the LDLs are removed from the blood, right? So you can see here statins are effective for not only lowering LDLs, but it also increases HDL, so this is the good cholesterol, and it decreases triglyceride levels. Some of the other effects is that it promotes plaque stability of atherosclerosis. So what happens over here is you have a blood vessel here, right? And for people with atherosclerosis, what happens is they'll have an atherosclerotic plaque. Right? And one of the chronic things with atherosclerotic plaques is it increases high blood pressure, because it narrows the lumen, the inside of the blood vessels. But the other thing that happens with atherosclerotic plaque is that sometimes the layer, the outside covering of the plaque can become rough, and it can rupture, right? And what happens when it ruptures is that it attracts platelets, and it attracts platelets to come and clump and form a platelet plug. And remember that the platelet plugs is the first step to forming a blood clot. And so what you have is you have a platelet plug forming, and then that then causes a clot to form, right? And we have a clot forming. What happens is blood can't go through, right? So you have decreased perfusion, and also the blood clot can break off and get stuck somewhere else, right? So you've got an increase for cardiovascular events with this. And so what happens is the statins promote plaque stability, and so it means that it's less likely to cause clots, it's less likely to attract platelets, and it's less likely to actually rupture. Right? So the perfusion doesn't change necessarily above and beyond what happens with the chronic effects of atherosclerosis. Right? And it also has so it promotes plaque stability, and by promoting plaque stability, it reduces the risk for cardiovascular events, and it also increases bone formation. Right? So therapeutic use for statins is to reduce high cholesterol in the blood, so hypercholesterolemia. It also proves to be the primary and secondary prevention treatment for cardiovascular events, and it helps to prevent future cardiovascular events and to help to prevent any more. Right? And it's used in therapy after a myocardial infarction, and in diabetes, again, to lower blood cholesterol, to promote plaque stability, and all that kind of stuff. In terms of the dosing, it's usually given once in the evening, and it's given in the evening because cholesterol synthesis occurs at night. right? So again, you can give it in the morning, but it's not going to have as much impact compared to giving it in the evening, when it basically can decrease the synthesis of cholesterol, which happens at night. Right? The response is seen within 2 weeks. It's maximal within a month or so. Right? So you've got low dose of statins can decrease LDLs by 25%. High dose of statins can decrease LDLs by 65%. So those are all good numbers. Other drugs that are used to lower blood cholesterol levels are listed over here. So you've got niacin, nicotinic acid, which reduces LDLs and triglyceride levels by increasing HDL levels effectively. And you've got bile acid sequestrants that basically are a drug that binds to bile acid and increases the excretion of bile acids. And this is important because normally bile acids are recirculated about 15 times, right, over here, before it is actually excreted. So by binding to bile acids and excreting the bile acids, what happens is it's forced to make new bile acids. And the thing is, bile acids contain cholesterol. So basically it takes cholesterol out of the bloodstream in order to actually synthesize new bile acids. You can see here the adverse effects are GI, because what happens is it not only grabs bile acids, but it also grabs other cholesterol containing food products or other drugs, right? So it can cause constipation, nausea, indigestion, and bloating. And like I said, it can also bind with other drugs and cause the excretion of those other drugs. So it makes those drugs, the amount of absorption of those other drugs decrease, right? So it can decrease the effectiveness of those other drugs. Now, the latest drug in this class, colacevolin, doesn't decrease absorption of fat-soluble vitamins or the absorption of other drugs, right? So that's actually quite a good thing, because it actually addresses one of the main adverse effects that is true of the earlier bile acid sequestrants. All right, this drug inhibits cholesterol absorption, and then you've got fibric acid derivatives that are also good for lowering triglyceride levels and for increasing HDL levels, right? It has minimal effects by itself, and so I think it's usually given in conjunction with other drugs. Now I'm going to talk briefly about angina. So angina is chest pains, and angina is due because the demand for oxygen is greater than the oxygen supply, right? So what you've got here is you've got what happens during rest with a healthy heart and a heart with coronary artery disease, right? So what you have here at rest is that the oxygen supply and the oxygen demand is actually equal. But what happens during exertion is that with a healthy heart, again, the amount of oxygen that's demanded matches the amount of oxygen that's supplied, right? Whereas in a heart with cardiac coronary artery disease, what happens is demand is much greater. So you can see how the oxygen demand load is heavier, and the supply of oxygen is much less, and that's where you can get angina, right? So what we want to do is we want to minimize the demand for oxygen in order to actually bring it back to what happens with a healthy heart during exertion, right? So as I said, long term, what you want to do with angina is you want to prevent it, right? So you want to prevent myocardial infarction and death, because that's one of the consequences of untreated angina, and you want to do that long term by having the patient use cholesterol lowering drugs or antiplatelet drugs. So we've talked about cholesterol lowering drugs before. We're going to talk about antiplatelet drugs after this. And also, secondly, you want to prevent angina and you want to prevent myocardial ischemia in the future. And to prevent that, nitrates to make the blood vessels increase in diameter and therefore increase blood flow, right, and decrease blood pressure. You want to also use beta blockers to reduce the oxygen demand, right? And so that reduces workload of the heart. And you want to use calcium channel blockers again to reduce the workload of the heart and also to reduce blood pressure, right, by causing vasodilation of the arterial blood supply. So out of this list, we've talked about beta blockers, we've talked about calcium channel blockers, we've talked about cholesterol drugs, cholesterol lowering drugs. And so we're going to talk about nitrates, and then followed in the end with antiplatelet drugs and anticoagulants. So nitrates, nitroglycerins are vasodilators, right? So what happens is they actually make the blood vessels bigger. And so if you have the blood vessels being bigger, you have an increase in blood flow and a decrease in blood pressure, right? So you have blood flow and oxygen supply to the myocardium, so the oxygen supply is greater, right? And it's a primary treatment of angina pectoris because it can actually get to the cardiovascular circulation quickly, right? So it can be given frequently, 3 times 5 minutes apart, and then if still in pain, call 911 or go to emergency. The adverse effects is because the vasodilation can occur rapidly, it can actually cause orthostatic hypotension when a person basically stands up or sits up very quickly. It can cause headache because of vasodilation in the cerebral arteries, and it can cause reflex tachycardia where the heart beats faster in order to compensate for a decrease in blood pressure. All right, so those are the adverse effects. And then caution, you have to actually make sure that the systolic blood pressure in the beginning is not less than 90 millimeters mercury, because it might actually drop that blood pressure quite substantially and cause more damage that way, right? Never stop nitrate therapy quickly, because vasospasm may occur as a rebound mechanism. And tolerance can occur within 24 hours. So again, use the lowest possible dose for the shortest period of time, and also build in a drug-free period. All right, so that's all I'm going to say with vasodilators. The last group of drugs we're going to talk about are anticoagulants. And so with this, and antiplatelet drugs and thrombolytics. So they're all together. And so what we want to do with this is basically decrease the amount of thrombus, right? Thrombus or thrombi is basically clots, right? So what you want to do is you want to decrease clot formation. Because again, what happens is you have a blood vessel and you have a clot forming over here. What happens is 2 things. One is that the clot can actually decrease perfusion, right, on this side, right, because the clot's basically blocking it. And the other thing is that the clot can actually break away and become an embolus and basically block a blood vessel further upstream. Right, and then you can have infarction, ischemia, and infarction further upstream. Right, so what you want to do is you want to decrease the possibility of thrombus forming, or if you have clots forming already, you want to increase the rate that it's going to dissolve. All right, so what you have here, let's go through this the system. So you have stage 1, where you have formation of platelets, platelet plug, right? So over here, platelet plug forms, it clumps together, and once that does, it initiates the clotting process. All right, and then once the clot forms, it at some point it needs to be broken down by this process called fibrinolysis. And so what you see here is you can see 3 different pathways of actually reducing the number of clots. The first pathway is by reducing, right, the possibility of platelet plugs forming. The second way is reducing clot formation, right? And this fibrin over here is an insoluble thread that actually forms the basis of the clot, right? So that's number 1. That's number 2. And then the third way is to increase fibrinolysis, right? Lysis means breakdown, fibrin of the insoluble clots. And so if you break down the insoluble threads, then you get rid of the clots. Right? So this is the third mechanism. And so what we're going to do is we're going to look at these 3 pathways as mechanisms to actually prevent the formation of clot, and as I said, to dissolve clots that are already there. So the first one are antiplatelet drugs. So antiplatelet drugs work to inhibit the cyclooxygenase enzyme, and the cyclooxygenase enzyme, through some mechanism that we're not going to actually go through, basically inhibits the chances of platelets forming. So you can see here it's used to prevent MIs and to prevent transient ischemic attacks, so strokes. It's effective against blood clots in the arterial system. So some examples are aspirin, Plavix, and other non-steroidal anti-inflammatory drugs, right? So you can see over here, aspirin blocks over here, Plavix blocks over there, all right? One of the notes with this is because it inhibits, it irreversibly inhibits the enzyme, right? What happens is you need about 7 to 10 days before new platelets are made, and the platelets have got the cyclooxygenase that are not inhibited. Right? So what happens is platelets last for 7 to 10 days. So you've got aspirin, basically blocks the cyclooxygenase enzyme, and aspirin prevents platelet plugs forming. Right? So aspirin prevent platelet plug forming in platelets. Say if I take it today, today's a Monday, on Monday. Right? As I said, these platelets last 7 to 10 days, right? So if I stop taking, say last dose is today, those platelets will still last, a lot of them will still last for 7 to 10 days. And so what happens is the effect of aspirin actually will last 7 to 10 days until new batch of platelets are synthesized, and these platelets, the cyclooxygenase, are not inhibited. Right? So that's why sometimes with a person that's going to undergo surgery, they might say, you know, you have to stop taking aspirin for a few days before surgery, and this is the reason why, because the aspirin actually takes, even if you stop it today on Monday, it will take a few days for the effects of aspirin to actually wear off. Second group of drugs are anticoagulants. So basically it stops the clot from happening. And so what we have is we have 2 different drugs, right? So this is the clotting cascade over here. I'm not expecting you to remember all the different factors. So I'm not expecting you to remember that factor 12 gets activated to become 12A, and factor 12A then activates factor 11 to be activated to be 11A. So you don't need to remember that, right? But what I want you to remember is just a couple of things. So I want you to remember the difference between heparin and warfarin, right? Heparin cannot be given orally. Heparin inhibits all the yellow factors, right? Inhibits thrombin. And it has a rapid onset. Warfarin can be given orally, and warfarin affects a different subset of factors, of clotting factors, so it affects all the green clotting factors. All right, and these green clotting factors are special because they need to have they incorporate vitamin K into it, right? And we'll talk about why that is the case later on and what consequences it has. So we're going to talk about heparin, right? So heparin activates antithrombin, and antithrombin basically works on decreasing the effect of thrombin and decreasing the effect of factor 10A, right? So it's most effective against venous thrombus. So it's administered either IV or subcutaneously, and it takes minutes for it to actually work on it. You need to monitor someone who's on heparin because you want to make sure that the risk of clots forming is decreased, but you don't want them to bleed out. So you need to keep actually a good dose so that it prevents hemorrhage, but it stops clotting, right? And you do this through monitoring activated partial thromboplastin time, or APTT, right? So that's normal heparin. Now with this, because you need to monitor APTT, it's kind of a pain, right? Because it takes up resources. And so they've come up with low molecular weight heparin. And the difference between normal heparin and low molecular weight heparin is this. So low molecular weight heparin only inactivates factor 10A, right? So it has no effect directly on thrombin itself. So that's one thing. And the other thing is that you don't have to monitor APTT, so it basically saves on resources in that way, right? So and you can also give it on a fixed schedule. So it's less follow-up because it's more stable, and therefore you can get away with just giving it on a fixed schedule without actually monitoring it. Right? So again, those are the difference between heparin and low molecular weight heparin. Now what you can see over here is that heparin, whether it be normal or low molecular weight, cannot be given orally, right? Because it can't be given orally because it's too large to be absorbed. And so what we've come up with is another anticoagulant called warfarin. And what warfarin does is it basically inhibits all these green factors. Right, a different set of factors than heparin, and these green factors are called vitamin K specific clotting factors because they incorporate vitamin K into it. Okay, so again, adverse effects: hemorrhage. You want to stop clotting without promoting hemorrhage, and you want to actually have the patient avoid foods that are rich in vitamin K, because what happens is if someone has ingests foods that are rich in vitamin K, it actually increases the synthesis of these factors, which then negates the effects of warfarin. Right? Good thing with that is that it can be given orally. Bad thing is that it takes days to actually for the effect to kick in. And the reason why it takes days for the effect to kick in is because of its mechanism of action. If you look over here, it inhibits synthesis of these proteins, and to inhibit the synthesis of proteins and for the effect to be felt, it actually takes days, right? So that's why it takes days for it to work, because it's a slow process where all these factors are not being produced in as great amount. And again, because there's a risk of hemorrhage, you want to also monitor, and you monitor using what's called the INR, the International Normalized Ratio, and you want to keep it between 2 or 3 days. And also, the half-life of warfarin is 2 days, so it's really quite a balancing act to make sure that it gets maintained and kept within therapeutic range without going into toxic doses. Last group of drugs in this category to actually decrease clots is thrombolytics. So thrombolytics break down, lysis, clots, right? So what happens is the substance, the protein that's involved in actually breaking down clots is something called plasmin. So plasmin is present in the inactive form as plasminogen, and so what thrombolytic drugs do is it increases the conversion rate from plasminogen, which is inactive, to plasmin, which is active, right? And when you have plasmin, then it helps to break down clots. So you see over here, plasminogen is inactive, plasmin is active, and what it does is it helps clots to dissolve. All right, and so that's what it does. So you've got it forms an active complex, and it helps clots to dissolve. And so it dissolves existing clots, and these are the two drugs that are used, typically used as thrombolytic drugs. And then just to finish off with, I'm going to just give you an overview of various strategies to minimize the risk of bleeding. So you've got over here, minimize manipulation of patient, avoid sub-Q and IM injections, because you can't actually monitor the flow of the drug from from the muscle or under the skin to the systemic circulation. Minimize invasive procedure, because that increases the risk of bleeding. Minimize use of concurrent use of different anticoagulants or different antiplatelets, and then lastly, educate the patient, right, about the dangers of hemorrhage. So signs of bleeding can include reduced blood pressure, elevated heart rate, and as a compensatory mechanism, discolored urine or stools, because the blood actually enters into the urine and stools, presence of bruises, petechiae, and hematomas as a indication of bleeding, persistent headache or faintness, suggestive cerebral hemorrhage, pelvic pain, suggestive of ovarian hemorrhage, and lumbar pain, which is suggestive of adrenal hemorrhage. And on that cheery note, I'm going to end the recording. Thanks.